Good afternoon, everyone, and welcome to this afternoon's webinar on triage. Our presenter today is Jane Butcher from WAFA, the WA Primary Health Alliance. So if you have any questions, please use the chat box, which you'll see on your monitor. And if they're technical questions, I'll address them throughout the webinar. And if they're questions for Jane, then we will attempt to answer as many as possible throughout the webinar or hold them till the end. And if we don't get to answer any of them, then we will respond to you directly after the webinar. So you are all muted. And if you do have any technical questions, please call Rural Health West if you can't use the chat box on 63894500 and ask for the webinar, and our reception staff will help you out or put you through to me. So I'd like to welcome Jane to start the webinar. Thank you, Jane.
Can everybody hear me? Is it going okay? So my background is that I'm a nurse. I've worked in general practice for 28 years, and I've also run a small rural practice, so I've got some idea of what you're facing out there. And let's hope that we cover most of the things that you want. So this presentation is put together by WAFA and Rural Health West together, and we're just going to talk about triage. The objectives, the things we want you to learn today is to understand how vital triage is to timely access to care, what are the core principles, what is the role of the reception staff and the clinical and non-clinical team in effective triage, and then let's have a little think about policy development and risk that's involved. So let's just start with a definition. Triage is patient prioritisation on the basis of where resources can best be used or are most needed. And this is a concept that actually came out of the Napoleonic Wars, which is a very long time ago, and it really hit its straps in Vietnam, and then came across from the battlefield really into the hospitals and now on into primary care. So what we're seeing is a mismatch between what's required and what's available, and how timely can we make it for people, and that's a really big issue in general practice. So the RACGP standards talk about access to care and scheduling care and opening hours, and sometimes I give this talk and I actually call it scheduling care, and we talk a lot more in that presentation around you know, having availability of different sorts of consult time. So, you know, if you've got a scheduling care for someone for chronic disease, how do you fit the emergency patient around that? And it's a bit more of an open discussion, but today we've got quite a bit to get through, so I'm hoping that if you've got any questions on those issues, we can maybe have a discussion towards the end. But for the purposes of the standards and meeting accreditation requirements, it is necessary to actually have a triage policy, to have people in your practice skilled in how to use that policy. So the issues are, we've got a GP shortage and there's long waits for appointments and all that about balancing safety. There's a clinical risk involved. If we don't see someone, what might happen to them? There are legal considerations, and we'll talk a little bit about this case, Alexander versus Heiss in 2001, because it's really the defining case around this issue of triage here in Australia. And finally, do we have a practice nurse or not? Is it their role to do all the triage in the practice? These are some of the things that some practices are doing. They have a nurse who actually just does triage. So consider that. How does that fit with your practice? Probably not at all, because most practices don't have a nurse there full time. So the defining case, this is in the New South Wales Supreme Court between Alexander versus Heiss. Now, Mrs. Heiss was the receptionist in her husband's practice, and Mrs. Alexander was a patient. Mrs. Alexander attended the practice late in the afternoon, saw the doctor, and on her way out wanted to book an appointment for her husband who had a headache. And subsequently an appointment was made for sometime in the next week, about 7 days away. unfortunately, Mr. Heiss collapsed with a really huge bleed in his head prior to that appointment and subsequently died about 12 days after the appointment should have been made. So this is a bit of an issue. Mrs. Alexander has sued them to say that they had a duty of care to have seen him and he should have been seen more quickly than he was, that the appointment wasn't appropriate. Mrs. Heiss, on the other hand, said that she hadn't been told the full symptoms that he had. If she had heard that he had a headache that wasn't relieved by Panadol, she would have made him an earlier appointment. She also asked the Mrs. Alexander how was her husband, and she was told that he got up and gone to work that morning, so she presumed that he was a lot more well than he was. And then this ended up in Supreme Court, and it was a really interesting case because there was no blame attached to this and it was let go. But what was really interesting was in this finding he actually said that a well-trained receptionist would inquire about specific complaints, their severity and duration of their complaint, and that it was needful to have training for reception staff and a way for them to actually record, because in this case there was no record of this conversation. So we needed to have good records so that if this did come to court there was evidence as to what had happened. So although there was no blame and there was no findings against Mrs. Heiss, this has influenced how we've gone since then in general practice around triaging. So it's a really interesting thing. So the core principles of triage are really that you have to have a policy or procedure that provides consistency, and triage should be following a logical thought process. There should be some trigger questions, some things that we always ask, and then some further questioning that allows us to classify and determine how acute this problem is. And then once we've identified high-risk patients and concerns, what do we do with them? How do we deal with it? And then making sure that we actually record those outcomes. And this is something that obviously is done quite well in hospitals and not so well in general practice, because we usually don't have a really good system. And if we do have a system, it may not have been customised enough to the practice where we're actually working. So those are some of the things that we'll need to think of as we're going through and looking at policy. So what do we need to think about if we're going to write a policy, if we're going to look at how our practice deals with people? Well, we need to have staff that are able to quickly and accurately identify our patients who need care. So there has to be appropriate training. It has to be responsive, so we can fit in someone who's really, really urgent as opposed to someone who may not need to be seen for a few days. And we need to have everybody on the staff following those procedures. And as I said before, the systems for documenting. And this means that your reception staff may require to be able to document either into a patient notes or somewhere the conversations they're having. And it can be really tricky to know when you should be documenting, but anything that leaves you with a bit of a feeling that maybe this could go wrong is definitely something that you should be documenting. So when you're developing the policy, you have to think about what comes into the practice, who you've got on, when you've got people on, what are your doctors skilled in, and where are you? So the practice that is in the Kimberley as opposed to the practice that is, you know, sitting next door to Fiona Stanley Hospital will have a different triage policy because you've got different needs and different ways of calling for help even. So it has to be customised. You can use something that's out there as a basis for what you're going to be doing, and it gives you good guidelines, but it has to be something that can be followed in your practice. There's no point putting call 000 if 000 is not the number you call if you've got an emergency. Once you've developed it, everybody's agreed, the roles are defined, so we know what the practice nurse is doing, we know what the receptionist is doing, we know that if there's an issue that they need a doctor to respond to, how that's going to work. Is there going to be a doctor who's dedicated for the day to be the man who, or the woman for that matter, who takes the emergencies, or are we actually just going to have an ad hoc, let's knock on the door and say help, help? And then the doctors are aware if somebody does do that, that they have to come out and provide some assistance and some more expert knowledge in what's happening. So if you haven't got one, and most of you will have one because I'm pretty sure that you all have a copy of the Rural Health West practice manual, and in that there is some information about triage policy, and there's also the pop guns tool, which we'll have a quick talk about in a moment. So that's a guide for making a decision at the front desk. And so I know you've got that, but I'm not sure how much you've actually thought about it and actually considered what the implications are and how that was going to actually work in your practice. So that's that first bit about developing it and then implementing it. So making sure that everybody's on the right page, having a practice meeting and a discussion, making sure that everybody has the same guide. So this is particularly in a large practice where I've been into large practices and they've got 6 or 7 receptionists and there's only one guide, and that's stuffed in the back near the fax machine or somewhere. So nobody's actually got access to it. So making sure that if you've got reception staff, they've got access to what they need to guide them, particularly new staff. Train all your staff in how to answer the phone, train all your staff in how to ask some questions and how to follow the procedure that you have in your practice. It's important that that happens because then you get consistency. If you don't have consistency and you can't point to it being a consistent response, if there is an issue and it does go to court, you've got no evidence. If things normally happen in a particular way and you go to court and say, well, this is our usual, then that's a greater standing, and they're going to be a bit more keen on you, a bit more lenient towards you if they can see that you usually have a set way of dealing with things, and they are there may have been a slip up in this case, or that it was actually followed but unfortunately things didn't go well. And it may be important that you provide information to your patients. And this is if you're going to change the way you do your appointments. So, for instance, some practices have a lot of bed block, so to speak. They have seat block, consultation block, whatever you want to call it. So practices are full and they're fully booked and nobody can get in for weeks and weeks and weeks. That is not a good situation to be in, because it means you can't slip these people in who need to be seen, you can't deal with them, and you have a duty of care to do so. So you may need to free up more appointments. You may have to say to patients, well, we're not actually going to book you back in 4 weeks' time because you may actually not need to come back. And so that would allow there to be more appointments available more quickly. And all those things, if you're going to go down that track, you have to think about it and think it through and make sure your patients are informed. Some practices will call, or some doctors, I suppose, will call people back repeatedly. So let's give them a set of antibiotics. Let's get them back in a week to see how that's going, and then let's, call them back in another week for something else. And so you're actually blocking up your appointments when you don't need to. Anything that you're introducing, any policy, you need to go down this sort of list and then set a date and make sure you've got equipment, the right equipment. There's no good having equipment in your emergency bag or your emergency trolley if your doctors can't use it, or your nurses can't use it. It's not up to scratch, or it's out of date. And finally, any policy that you put in place must be reviewed. So you must set a date to review it. And the other important thing is about ongoing orientation for new staff, including GPs. Make sure that they're aware of how triage is handled in your practice, how the services are in your area, especially if you've got a lot of GPs moving in and out, so you've got registrars or locums coming in and out. They need to know how they respond. So some of the benefits of having a triage policy and a real directed way of dealing with it is that there's increased safety for the patients. You've managed your risk, you're getting consistent decisions and actions, and you've got appropriate referral. And I don't mean referral to services. What I mean is that if it comes into the front desk knows when to refer it to the nurse knows when to refer it to the doctor, and then the doctor knows whatever it is that he knows, he will deal with it and then send patients to the hospital as required. So appropriate referral is about just making sure that the right person at the right time is seeing the patient, not necessarily referral for specialist treatment. Having a triage decision support is really what that's about. And then your policy is really good for practice accreditation, and it should reflect current best practice. So that can be a little more tricky, especially if we're not really sure what current best practice is. And the way to sort of probably monitor that is to be looking at coroner's reports, at what's happening in the Resuscitation Council, just what's happening with standards. So I think that the new RACGP standards will be out in a few, well, probably not too distant future, as these ones have been around a long time. They usually spell out what's best practice for us in general practice. Looking at what's happening in hospitals, just having a bit of an idea of what's going on. So triage tools, most of you have some tools. The on-hold message, you know, the one that says if you're having chest pain or breathing difficulties, ring the ambulance. So think about what you actually have in your or on your on-hold message. Is it appropriate for where you are? Hopefully it is. Is it really, really long? I've run a practice recently, and by the time I got to choice 9, still hadn't heard that if there was an emergency I should be ringing an ambulance or seeking further help. I've also run practices where by the time you got through the whole menu, there was nothing, it just dropped out. So that wasn't very helpful. So you sit down and actually listen to your on-hold message and think about it. Think about it if you were a patient on the other end and you had an issue. You know, you had your daughter drowning or having a fit, or your granddad has just keeled over having lunch and is, you know, going blue in the face. What would you do? How would you feel? Could you listen to this? What would it mean? So it's really a case of just thinking about it from the patient point of view rather than just the information that we want to give them. Decision-making frameworks, that's the pop guns and things that we'll talk about a little bit later. Practice notices, things such as if you're having chest pain, you know, please let the nurse or the receptionist know, don't sit there quietly. And patients will do that. They will quietly die in the waiting room rather than tell you that there's an issue. It's also a little bit of a catch-22 because then some patients will twig that if they say they've got chest pain, they'll be seeing quicker. And I've certainly had a practice tell me that their patients have cottoned onto that. So just make sure that they're appropriate and that what the patient is saying is actually meeting what is said in the notice. So if they're saying that they've got chest pain, do they actually look like they've got chest pain? Do they look pale, grey and sweaty? And wall charts are just another way of having the triage decision tree up around your practice so that you can follow it quickly without having to really think too much. So most of you will have seen something like this decision-making chart. This is the pop guns. This has been around for a very, very long time. It comes in many different forms, but essentially it's the same. Essentially you have red, orange, green, blue, and not so very important, and let's just wait stuff. So as I said before, this is really very good, but does it actually reflect what happens in your neighbourhood? And so call 000, inform ED. Well, your GP may be the only ED. You may not even have a hospital. So what do you do then? And go to casualty. So that means if you know you're in category B here and you've got a head injury or a severe allergic reaction, you have to go to the emergency department. Well, that's fine. How long is it to the emergency department? if you're in Kalgoorlie as a doctor and you're getting this call and the person's out 300 kilometres, is that appropriate? Probably not. So that's what I'm saying. You need to look at these things and make sure that they are appropriate for where you're working. They look lovely and their creditors are really happy to see them, but they're not actually really useful to you unless you've customised them. And most people these days are pretty good with a bit of a Word program or maybe some publisher or something who can whip these things up. So it's really a case of thinking about it and having a look at what you've got in your practice and maybe going back to it and making sure that it actually meets your needs. I saw one once that said something about jellyfish stings. I don't think that is this particular one, but it did amuse me as the practice was actually out in the desert areas, and I don't think jellyfish stings was going to be a problem for them. Or maybe they were. So, yes, don't you love this? I love this little picture that I found, immediate, delayed, minor, and send them to the morgue. Well, that's really where it has come from. That's from a disaster planning thing that I went to, which is really good. So when we have a patient ring up, we have to ask some screening questions. We assign a category, preferably not send to the morgue, and then we can give some advice, and that advice could just be come to the doctor. It could be, take some Panadol and call me back. It could be anything, and then we need to document the actions, and make sure that we've followed up on anything, so that if we've given someone an instruction, that we follow up and make sure that it actually did happen. So if we're saying to them, go to hospital, follow up and make sure that it went to hospital. So screening questions. And remember that some of the people that come to your practice, you won't actually know this stuff, or some of the people that ring in may not know, you may not know this. So you need to have a name and a phone number, particularly if they're off-site and they're having some serious issues. You need to be able to phone them back. You need to know who they are. You may be able to find their notes, or you may not if they're not unknown to you. Age and sex is important. What is the nature of their problem? Is it new or old? Is it something that's suddenly come on? How long has it been there? How severe is it? What makes it worse? What makes it better, if you've got time for any of this, or any previous major health problems? So that's just a quick screen, and it gives you a bit of an idea. If they've got some major health problems and they've got something new and it's really quite severe, and they're very old or they're very young, then you may want to bring them in more quickly than if it's something that they've had for a long time and it's just a little bit worse. So it's just trying to gauge what's happening out there, and that's a little bit tricky. As I said, these are the sort of categories we would be looking at. Red, where it's an immediate response is required, something where we aren't going to deal with it in the practice and they should be going to an emergency department. If we're not really sure, it sounds reasonably serious, but maybe not as urgent as those other two. If you're on the reception, you might be wanting to ask the nurse or the GP and discuss that with them, and then probably bring them into the practice or send them to the emergency, depending on what advice you're getting. Or maybe you're handing the phone over to the GP or the nurse to carry on the triage process. If you've advised someone to call an ambulance, you should still be notifying their GP. If you've advised them to go to the emergency department, you should still be notifying their GP, and notes should be made in their notes as to what the advice was. And make an appointment within 24 hours. Most people really want to be seen today. That makes it tricky to tell them maybe you're not so sick, and that's often better coming from the nurse than the receptionist. But you may be able to get them to come tomorrow if you're saying, we're really busy, we don't have a spot. I've spoken to the nurse, I've spoken to the doctor, and come in. And always if you're making that call, always say, if you get worse, go to the emergency department, call back, whatever is appropriate for where you're situated. So some of the high risk categories that we have are obviously anything to do with your airway or your breathing, anything where somebody's unconscious or they're bleeding severely, that their circulation has collapsed. And then we need to think about abdominal pain, chest pain, shortness of breath, severe headache. All these things are things that should be raising the little question mark in the back of your mind as to how severe this is and what's happening, and maybe we should be thinking about it. If it's a severe headache and they've already tried the pills that they normally use for their migraine and it's not getting any better, then they should be being seen. Does that need to be seen in the practice, or does it need to go somewhere else? Again, that depends on a lot of things. If it's the end of the day and your doctor's about to go home, then it may be better to be seen in the emergency department, which may actually still be your doctor anyway when you're out in the country. But it's about what can you sustain in your practice. Other high-risk categories are children, and that's because they have little reserve. Children are quite small, as you have already seen, and they don't have enough body mass to keep up their temperature, to deal with a lot of things. And if the mother is concerned, if they give you more than one call in 8 hours or in a short time frame, there's an issue and they do need to be seen. We can't just keep fobbing them off as worried parents. Children who have got chronic illness or who are premature will drop like a bundle in no time flat. They really can deteriorate quickly. And those premature babies, even as they get older, it takes quite some time for them to catch up in multiple years. They're often not even caught up by the time they're 6 or 7. They're still way behind. Infants who are under 6 months, again, very small body mass. They don't have much reserve. They don't have much water on board, so they dehydrate quickly. If a baby hasn't weed in its nappy at least 3 or 4 times a day, there's an issue happening there. A child who has failed to respond to prescribed treatment is always of concern. So if they've been in to see the GP the day before and now they're getting worse, then you probably need to call them back. You probably need to have a discussion with the doctor and see what he's got to say about that. But children really do crash quickly. Any child that's really, really quiet and pale needs to be seen. So you've got to think about these things. You've got to make sure that these are covered when you write your policy. And stroke can sometimes be quite subtle. So I love this, FAST. I find this is a really good little acronym and most people can remember. FACE, any drooping. I mean, this is a bit exaggerated on the bottom, but this is from the Stroke Foundation. If they've got a problem with their arms, can they lift things? Can they hold things in an arm? Has their speech suddenly slurred? And if somebody's having a stroke, then time is critical. So that's time to buy them a better recovery in most cases. So the Stroke Foundation has some quite good information. If anybody wants to go and have a look at that, you may want to put this this picture up. This you can just pull off the website. They actually have some great resources there. Other people who are in high risk categories are patients who are immunosuppressed, which means that they may be having cancer therapy, they may be on long-term steroids, they may be people who are got something like rheumatoid arthritis and the medication they're on is suppressing their immune system. Again, these people are unable to fight infections and often don't have great reserves, so they're high risk. You've got to be a bit more suspicious of them. Anybody who's got a bleeding disorder, they just seem to fall apart, unfortunately. So particularly if they've cut themselves, that's a definite issue. They can, if they're bleeding internally, they can quite easily develop ulcers and things and start to bleed internally, which we won't be able to see, but could make them unwell. any person who's pregnant, preferably female, is a high-risk category just because she also is immunocompromised by having this child. The child is also a worry. So anybody who's pregnant goes up the list. Anybody who's had recent surgery, complications from surgery are often missed. So if they've got problems and they've had recent surgery, then they need to be looked at. And anybody with an unstable chronic disease, so particularly diabetics, if they're unstable, they can have a hypo very quickly and need attention. They could be going the other way. People in chronic heart failure who've got breathing issues, so they've got airways disease or obstructive pulmonary disease, then they need to be seen if there's an issue. If their breathlessness has increased, if they have fever, they may be harbouring pneumonia and things, so you need to bump them up the high risk category. So these are things when you're writing your policy, you need to make sure that you're sort of covering. So what about the role of the receptionist? Well, the receptionist is the most important person in the whole practice because that's the first person they see. It's the first person they speak to when they ring up. So they are the most important people in this whole process. And it's really important that they understand the process that happens in your practice, that they understand what their responsibility is and who to go to if they're having issues. So make sure that the receptionists do know what the policy is and what the framework is for them to support them. They have to be able to assess patients within their capacity, which doesn't mean that they are expected to be able to ask the same sort of questions as the nurse or even the doctor, but they are expected to have some idea of when a person is in need of more urgent care, and they have to know where the right person is. And as I said, if they're unsure, if they've got support from a nurse, then maybe it should go to the nurse. If you don't have a nurse, then obviously if they're unsure, it should be being discussed with the doctor. So where's the source of care? Is it appropriate for them to come to the practice, or is it more appropriate for them to go to the hospital? Their other role is to follow the instructions of the clinical staff. So once they've involved the clinical staff, then they are able to call the ambulance, get bits and pieces, call the family, all that sort of stuff that needs to be done. It's important that your reception staff remain calm and reassure the patient. And it's really not a bad idea that they do, particularly if you don't have a nurse, it's not a bad idea if they do have some first aid training, and they should all be able to do CPR. And again, the reception staff should be able to document the steps and the advice they have given. So in the case of Mrs. Alexander versus Mrs. Heiss, if Mrs. Heiss had written down the advice that she had given to Mrs. Alexander, then we might have had a clearer idea of what was happening. So it's really important that the reception staff are able to document, whether you do it by giving them access to the notes or whether you do it by asking them to write some notes which are then put into the practice, into the patient's notes. That's a decision that you need to make. And it depends on how big your practice is to a large extent, I think. So as part of the reception role, they do the walk-in triage, and what they need to do is they need to be able to look at a patient, listen to them, they can smell them, they can ask questions. Obviously someone who walks in who's really dishevelled and complains that they've just been attacked has a much higher rate of triage than someone who just walks in and is beautifully dressed in their business suit and says they've got a bit of a cold. So it's easier to do walk-in triage because you can see the patient, you can get lots of clues from how they are. I mean, if they smell of alcohol, that gives you some idea of what's happening. If they've got wide dilated pupils and they look like they've been a drug addict, then maybe they are. Maybe that's important for you to know. And the other role that is really important is observing people in the waiting room. And that's what I was saying about the dear patient who sat in the corner and quietly died. Maybe if the receptionist had a bit more awareness of what was happening, then they may have been able to spy that there was something going on. And often, particularly in the country, you know your patients and you know them quite well and you know what's normal for them. And so you can tell when they're just a little bit off or they're really a lot off. So triage isn't super difficult. It's just about being suspicious. But telephone triage is what we do most, and that is really the most difficult. Um, and I know that this happens all the time. People are unsure of their illness, so they'll ring up and they'll try and gauge how sick they are by what you ask and what you tell them. So if somebody rings up, you may want to ask, as we said, who's calling, name, age and sex. Is it the patient or is it somebody calling on behalf of the patient? The phone number and address in case you need to call them back or the call drops out, particularly these days when we've all got mobile phones. The nature, duration, severity of the problem, symptoms, any previous health problems, surgery, change of medications. And as I said, if the patient is known, that will help you a lot with doing telephone triage because you can't see what they're doing. If you can hear, sometimes somebody will ring in and you'll be able to hear that there's a commotion in the background, and so you know that something is going on. It's important to know if it's the person rather than the patient who's reporting the symptoms because, again, they're interpreting what's being told to them. And you need to also gauge that for what information you give back to them. So if they're a patient and you're telling them something and they're ill, they may not be retaining it. You may need to actually talk to someone else and give them the instructions. So just think about all those things. It's quite a lot to think about. And we'll just quickly talk about the angry caller. And I know we get a lot of those. It's really important that you speak softly, you hear them out, you empathise. You can apologise, but don't ever admit at fault. It's apologising that something's is happening to them rather than that you have done something. And then once you've kind of calmed them down, take some actions, use reflective listening, and that's where you say to them, now just a moment, I hear that you're telling me this, is this right? So summarise the statements, paraphrase them, so change the way it's said a little bit, try and make sure that you've understood what they're saying. Sometimes that can be really difficult. Sometimes there's a lot of hearing them out before you can get to that stage. But it's really important. And people who are in distress may come across as angry, and if you can just wait and hear them out, you can probably get a really good conversation out of them eventually. And then there's the rambling caller, the one who can't describe the issue, and it's really quite difficult for them to clarify what they're talking about. So it's really important that you try and hone in on what's happening. Give them some open-ended questions. So, so how are you feeling? And then once they say something, try and close it off. So get a bit more information. So if they say they've got awful pain, then you go, give me a scale of pain 1 to 2. When did the pain happen? So you start out with a sort of broader statement from listening to them and then bring it down to give you the nuts and bolts of what they're saying. Focus on one symptom and one topic at a time so that you can get a really clear picture. Otherwise they'll be all over the place and so will you, and you'll be lost at sea. You won't have any idea what it really is happening and what's the one thing that really is the problem. So try not to be sidetracked. And it's really important to keep going back and clarifying and re-clarifying until you've got to what you think is definitely the issue. This can all take a little bit of time. It's a little bit hard on the front desk on a Monday morning when everybody wants to come in. So once we've listened to them and we've dealt with them and we know what's happening, closing the call is also an important skill. And sometimes it's really important to just spend that little bit of extra time making sure they understood the instructions, particularly if they've been distressed and we're telling them that they have to wait for an appointment. Make sure that they understand what the instructions were that we gave them. Make sure that they understand that if they are unsure that or something is getting worse, that they do come in. So make sure that they're comfortable. Ask them, do you understand? Can you tell me can you repeat the instructions? Do you understand what they mean? Can you tell me in a different way? So so that we're not just getting them to parrot it, but we are trying to ask them, do they understand? Can they show you in a different way? Can they paraphrase it themselves so that we know that they've got it? It's really, we know what we're telling them, but they don't necessarily understand it. If they're a bit distracted, they're in pain, they don't always listen as well. So it's better to keep to spend that time now and not have to face a coroner or somebody in court later on because you didn't make sure that they understood. So what's the role of the clinical staff? Well, obviously they must be responding to the clerical call for assistance. You know, it's not the role of the reception staff, the practice manager to manage these patients if they're here in the practice, or even if they're on the phone call. Sometimes it's really important that we get the doctor or the nurse to speak to the person on the other end of the phone. And they should be able to respond straight away. They shouldn't be fobbing you off. And it's important to provide advice and direction of care. So if it's someone that's well known to the practice and the doctor may have a really good idea of what the issue is, he may ask you to give some directions to the patient. He may ask you to bring them in. He may ask you to ring their daughter or their son to go and pick them up and bring them in. So they should be telling you what are the next steps that need to be done for this patient, and they should be taking over responsibility of the care. Once you have identified there's an issue, you've called in for help, the nurse or the doctor has come to give that help, then they are responsible. They should be taking over the responsibility of that care. And finally, let's talk about documentation, because none of this happened unless it was documented. And the reason we have to document is obviously around legal risks, to demonstrate that we have standards of care, so we can analyse what went wrong if there is an issue, and we can plan, demonstrate the plan of care. So if the patient then rings back, we've got a plan of care in place. We know what we're doing. And sometimes if you've got frequent flyers, people who ring up a lot wanting immediate appointments, if you've got a plan of how that's going to be dealt with, that's a really useful thing to have in your practice, as long as everybody sticks to the same plan. So if you don't already have it, make sure that you've got a record of the patient's phone number or you've updated the phone number. And this is particularly if someone has called in and you don't know them. Make sure that you have documented name, age, sex. Even if you don't see the patient because you refer them to the hospital, make sure that you do have a record of this. What is the nature of the problem, duration, severity? Did they have any health problems? What was the advice that you gave them? Because in the case of Mrs. Alexander and Mrs. Heiss, they hadn't actually seen that patient, but advice had been given, and that's why Mrs. Alexander came back to sue them, because she didn't think it was the right advice. So make sure that you've got a record. So yes, the assessment, obviously if the patient's there, you can do a proper assessment, or the clinical staff will be doing an assessment and working out a plan of action, what information was given, what interventions were done, what referrals were given. So in this case, it may be that the patient is actually being sent on to the hospital or a bigger hospital, and you're making sure that you've got the right documentation to go with them, and that documentation is also copied into your clinical notes. And then follow-up actions. if somebody refuses the advice that you've given, so if you've advised them that they need to come in and they refuse to come in, if you've warned them about anything, you make sure that you've definitely documented all that, because sometimes people forget that they refuse to come in and comply with what we were all talking about, what we had thought was the issue and what we thought was the plan of action. So make sure that you've got that all documented. It's a lot of documentation. And what is critical is if you have guidelines and protocols, if there's variations and there's reasons for that variation, then that must be documented. This is more for the clinical staff than for your reception staff, but your reception staff may actually have a protocol and deviate from it for a particular reason. It may be that it's just quicker and easier for mum to scoop up the baby and run next door to the half a block down to the ambulance rather than the ambulance being called out, things like that. Just make sure that if there's any deviation from what is normal, it's documented. Make sure that the follow-up instructions are given. I once sent a patient home with the instructions from the doctor that he was to go home and rest and call me back in an hour and speak to the nurse. An hour went by and he hadn't rung me. And then I rang him and he didn't answer, and then I didn't know what to do, so I rang him again in 10 minutes and I still didn't get an answer, and it went on and on. I spoke to the doctor who said, I'm really concerned, maybe you should call out the police and get them to go around and visit this man. Luckily, as I was about to ring the police, the man rang in and he'd just gone to sleep. And he'd had the best sleep he'd had for 4 years, he informed me. However, I'd had the worst chest pain I'd ever had in my life because I was so anxious, because the instructions hadn't been followed up and I thought he'd possibly gone home to die on my watch, and I had visions of the coroner and everybody else. So that was a bit sad for me, but okay for the patient. But again, make sure that the follow-up instructions are logical and that they are definitely recorded. And as we said before, any refusal with the for the care plan. And something else that's really important is if you're sending them somewhere, make sure that you document the method of transportation, because this sometimes does come up that somebody does have a car accident or it's been inappropriate that they should be travelling by car to access care rather than an ambulance. And so just make sure that if you're sending someone off, maybe to the neighbouring town, that it's in the appropriate form of transport and that they understand that it is important. There are patients who have been sent off and decided to have a few bongs on the way rather than get to the emergency department as required because they were anxious and they thought it would make them feel better. And so, just make sure that they understand that if they're travelling in their private car, what the risks are. Have they got someone going with them? There's no point sending someone off in a private car if they're the driver and they're the person with the issue. Make sure they've got someone with them. So these are just things to think about. And I'm sure you do think about them because they're pretty obvious, but sometimes they're not that obvious. And finally, reviewing the system. It's really important that you don't just put something in place and leave it in place. It should be monitored, it should be audited. Is it working? How do the reception staff feel about it? Are they happy with it? Does it work for them? What about the nurse? Is she being inundated with calls because the reception staff aren't familiar with what's happening? Are the doctors concerned that things are being missed? So just how efficient, how safe is it being followed? Do we need to make changes? If there's a breakdown in the process, why did it break down? Let's log the incident and let's look at how we can change things. And these are always great stuff to show the auditors when they come in for accreditation. They always like to know that you're making improvements, that you're responding to complaints and issues that are arising. And that's about it for the triage system. So the key points are, it is vital to timely access to care. It is vital that the patients get seen as soon as they need to be seen in the right place at the right time. That the policy that underpins the way the practice does triage is standardised for everybody, and that it is customised to the practice. That all staff understand what role they're playing, and reception staff are the first point of contact. They must be trained in the practice policy. They must understand what their responsibilities are. Good documentation is absolutely vital, and always continue to review, because that makes it timely and it keeps it current. And there are some resources for training. There's a triage guide for general practice. That is an online resource, and you can go in there, you can log in as a practice, and it actually does give you guidelines, and there's some training modules within that. There's Be Aware of the Warning Signs of Heart Attack and Stroke, which is an online learning module. They have one for reception staff. It's really quite good. The Australian Primary Healthcare Nurses Association has an online module on telephone triage, which is $99 or free for a member. Other resources are the Rural Health West Triage Guide to Urgency for Non-Clinical Staff. That's the pop guns we talked about. But again, as I said, it's really important to make sure that that is appropriate for where you're working. There are clinical practice guidelines from the Royal Children's Hospital, which can give you some indication of what you might be wanting to think about when you're looking at children's stuff. There's the Emergency Education Triage Kit, which is on the Health Department website, the Federal Government Health Department website. And finally, the Health Network in Northern Territory has the pop guns flowchart and a little booklet and a usual advice. And it's a little bit dated, but again, it could serve as a basis for you for putting together your own policy and procedure around this whole thing. And I think that we're there. Oh, one more thing. These are my references. And it's really quite interesting that they do still do a small amount on triage for the general practice nurses when they do their Foundations of General Practice Nursing module through APNA, which is or used to be the Introduction to Nursing and General Practice program. Obviously, the standards are always good to look at, and the other reference there is quite an interesting article which you might find interesting to read. So that's the end of that. So I've left a few minutes for questions. I'm not sure how we're going with questions.
Hi Jane, it's Laura here. We haven't got any specific questions so far, except for a note that some people may not have the Rural Health West policies and procedures templates or the practice management business support tool. So if you don't have a copy of that, please let Sonia or I know, and we can certainly make those available. Within the practice management business support tool, there is the Pop Guns poster, which is suitable for setting up in your reception counter as a prompter for your staff. And then also in the template policies and procedures manual, there's template policies and procedures, which you may use as a baseline to set up your practice. So if anyone does have any other questions, you can type them in now, or if you have a microphone, you can raise your hand using the raise your hand icon in the toolbar, and I can unmute you so that you can ask your question via microphone. Don't be shy. Okay, we're not getting any questions, Jane.
Well, that's fine. If anything occurs to anybody, if they were to send it in to you, and then we can work on answering it, that might be the way to go.
Absolutely.
And so everybody can have 5 minutes more free time before they get back to work today.
Excellent. Well, thank you very much for your time today, Jane. It was a really valuable webinar. For those that participated, a recording will be made on our website, so you can go back and watch it. And you may like to save that link for referring new staff as part of their orientation, which obviously triage should be a really important part of anyone's orientation. Uh, we have had a couple of questions just roll in now, people asking for copies of the handouts. Yes, they will also be emailed around to everyone who participated. So great.